Welcome to Navigating Financial Support and Medicare Changes, What Patients Need to Know in 2025. During this seminar, all patients will be in listen-only mode. There will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. Please remember the information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Rebecca Pauley. I'm Program Director at the LifeRock Group, and I would like to introduce our presenter for today. Jennifer Noonan, Vice President of Clinical Strategy and Patient Engagement at Accessia Health, is a dedicated healthcare professional with over 25 years of clinical nursing experience. Her vast clinical management background spans diverse healthcare settings, showcasing her expertise in program design and service delivery under rigorous regulations. Her career began as in emergency medicine in Louisville, Kentucky, where she spent 17 years in leadership roles and contributing to EMR clinical development and implementation. Transitioning into hospice and palliative care in 2014, Jennifer excelled in leadership positions for both adult and pediatric patients. A resolute academic, Jennifer holds degrees from Kentucky State University and Western Governors University. She was appointed to the National Association of Specialty Pharmacies Board of Directors in September of 2023. Beyond work, she is family-oriented, a martial arts enthusiast, hiker, and avid traveler. Thank you for joining, Jennifer. We're going to pass it to you.
Thank you, Rebecca. If I had known you were going to have to read all of that out loud, I probably would have given you a little bit of a different bio. I always laugh.
It's a great bio.
Well, I think that what I like to always start off with is just explaining kind of how I ended up here. So you gave some information about my background, but I think the piece of it that ended up leading me into a role where I was looking into access was, definitely in the emergency department, but more so than that, I worked in hospice care after emergency medicine, and that's where I began to see individuals who had really, really complex, rare health problems. And in particular, in the pediatric population, we saw a lot of folks who had, completely normal, if you would, lives until one day they discovered that in their genetics, there was something going on that just totally changed their lives. So I'm going to share my screen and give some information about Accessia Health and where it is I work, what we do, and what things are important this time of year. Are you able to see my screen okay?
Yes, perfect. Try advancing just so we know it works again.
Very good.
Perfect.
Awesome. All right, so this is probably what most would consider our most boring slide, but I always like to start with compliance because it is the foundation that all of our programming is built upon. And coming from a traditional background in direct care delivery and working directly with patients and providers, I was used to a different set of compliance guidelines that were set forth by CMS and Joint Commission, and those were very clear, black and white. But in the world of financial assistance, it's a little bit different. And what we do is operate under the guidance of the Office of the Inspector General. So we have what's called an opinion. And so the government says, as long as you do your business the way that you say that you will, we'll be okay with not causing any trouble for you. So one of those things that's really important, I always like to point out, no matter what group I'm talking to, whether it's patients, caregivers, providers of care, or even those who are in the world of donations and philanthropy, that one of the most important points about our programs is that we set those all up independently, and that we do that by asking of various sources that are going to give us information. So a lot of what I do in my role is I travel around and I get to go to scientific meetings and advocacy groups where I meet patients and providers who are experiencing these situations firsthand and try to get a better understanding of what it is that those people need for their specific type of health condition. And so that brings me to talk kind of about the state of healthcare and what it is we are looking at right now today. Some of these numbers may just seem like data, but when you really start to break them down and look at what they represent, it shows a pretty clear picture of some of the struggles that the US is having right now. So when we look at our actual group of patients that we serve currently right now in a variety of different disease areas, the average amount that we provide to people is about $3,700. And so when you look at how much that is compared to the average income of our patients, which is about $45,000 per year, we're already helping cover about 8% of what would have been gone with their income and the assistance that we provide. And we know that we can't provide assistance for everything that an individual might need. So this is really just taking care of a small piece. They say that on average right now in the US, individuals are spending about 14% of their spendable income on healthcare expenses. And so then when we look at the percentages of Americans that are talking about their ability to pay for their life-saving or absolutely necessary treatments, 38% of Americans are saying that they have had to go without treatment, or they've had to give up basic needs like food, rent, utility, fuel, transportation, any of those things that all of us require just to get by on a day-to-day basis are things that people are having to give up if they want to be able to pay for their medication or their treatments. 70% of households that earn at or below 40%. Uh-oh. Are you there?
We're here. Try sharing one more time.
Yeah, it just told me it's disconnected. Let me try. Sorry about that. Let me make sure you can see this. Okay. Is it showing again?
Yes, I see it.
Great. All right. We're going to switch to the next. Let me know if that didn't work. So Accessia Health, one of the things that we were originally created to do was about 25, 30 years ago, we saw an increase in medications and treatments coming that were really, really helpful to people. I always like to point out one of the first ones I remember seeing in the late 90s, early 2000s, when I was working in acute care was the introduction of Remicade or other types of autoimmune infusions that were really impactful and just changing the lives of people who were suffering from rheumatoid. But it was intended for us to be a safety net to help pay for people's healthcare out-of-pocket expenses that they could not afford because the pharmaceutical companies couldn't help individuals who had public insurance like Medicaid or Medicare. But what we've noticed over time is that one of the things that we have done to try to understand better what the needs are is do just some active listening. We've just recently formed a patient advocacy committee. It was a much smaller effort 2 years prior, and we've just refreshed it because we did notice right away that we were hearing all kinds of needs that we hadn't known about before we brought the patient's voice directly to the table. So what we're working on doing is extending our assistance beyond just co-payment assistance. We help cover travel expenses, other medical expenses that are related to the disease that the person is struggling with. And we also help with other things like diagnostic testing and other modalities around that illness. Back in May of 23, we changed our assistance model to be something called Your Assistance, Your Choice. And in doing this, what we wanted to be able to provide was some more flexibility within grant dollars. So used to be if you applied for assistance, you applied for a type. And if you needed help with your copay for medications, you would apply for copayment for medication. And you would be able to use that funding until it was exhausted in that one calendar year. But if you needed help with premiums, you would have to apply for a separate set of funding for premiums and so on. We had the same thing set up for medical expenses or ancillary and travel. So what we've done is taken those 4 different types of assistance and we've combined them so that individuals, once they receive their grant funding, if they qualify, they can use their funding for any of those items within their funding amount. So they can use it for copay for medication, premiums, medical expenses, a combination of all of those, and then travel is capped at $500 per program per year. We also provide some personalized support through our Access program. Many people don't know about this program, and it was really something that I didn't understand thoroughly my first year or 2 at Accessia Health. But what it is it's 2 individuals in a small office that we have down in Tampa, Florida, and they do nothing all day but help people who have been turned down for their Social Security disability benefits. So if that has been denied, we help people with resuming and appealing that application, and we have an 85% success rate. This is free. We do not charge for it. We do only take on certain diagnoses, and GIST is one of the diagnoses we've been helping with for many years, and so certainly we would be more than happy to help if anyone is struggling in that way. You just call our main number and ask to speak with someone in the Access department, and they'll get you transferred over. And one other way that we're doing things just a little bit differently here recently and isn't often talked about is we have some community-based programs that we're working with, trying to seek out and find individuals who may be overlooked or not hearing about or knowing enough information about diagnostic testing and the ability to get to and understand more about clinical trials. We're working on addressing these different social determinants of health as well, because we recognize that if people aren't able to pay their basic household bills, they're not able to think about their health care treatments or be compliant with them. I went too far. Sorry about that. There we go. So our application process, just to kind of talk through that a little bit, you can apply either by calling on the telephone and speaking with one of our representatives if you're someone who struggles with tech, or you don't have access to it, or you just don't like to someone to take that bit of a burden off of you. Once an application's been filled out, we look at the 3 different areas of qualification. The first is income-based, and that's run usually for, I think, 98 to 99% of our patients that apply. We get an answer back right away. It does a real-time poll on income and can let us know if someone is eligible. The guidelines for the criteria around the eligibility for income is listed on our programs page with each and every program, because some of them are a little bit different, but most of our programs start at about 500% the federal poverty limit. So we go through the verification of that. We also ensure that we have proper information about health insurance so that we can make sure we put people either in the private program or the public program. And then once we receive all that information, including a medical care provider statement, and just pointing out as well on that, if you've been a patient with Accessia Health before, or PSI as we were called in the past, we probably already have a medical care provider statement on file, and we know that this is not something that is likely going to change for many of the individuals that we serve. So you may already even have one on file, and if we do, we don't require that that be resubmitted time and time again. And then once someone is placed on service, then we have an adherence and auditing process from there. We just like to make sure everyone knows, if you've never applied for assistance with us before, when you do, please make sure you look over the patient policies pretty carefully. There's a few things in there regarding timeliness of filing and using your assistance every so often. In order to keep it active, we want to make sure that everyone's aware of. So what we noticed over the last 2 years was we saw a shifting patient need. It was moving beyond just the copay assistance, as I had mentioned. We'll talk a little bit about that in just a minute, but we definitely saw an increased need in help with travel, getting to and from places. We also noticed that there was a big need for an increase in the amount of funding people needed for their premiums. When we do recognize that insurance plans increase every year based on whatever they can base it on, cost of living. But we also have seen a bigger shift than that. It seems as though healthcare premium costs are already on the rise. More than 50% of our patients use services that were beyond just copayment. All right. So we talked a little bit about the legal assistance and that opportunity for use if someone needs that. We also have an educational series on our webpage, Amplify Your Voice, Control Your Care. This is a webinar series that we've been putting on each year. Last year, we focused a lot on the changes going on with CMS and Medicare and the smoothing plan. So we'll talk about that in just a minute. But we also wanted to bring up that we have case management for our patients. And so when I say case management, we won't be able to help people navigate or get through scheduling appointments or travel arrangements. But what we can do is help people make decisions about their health insurance and their premium or their supplemental plans. So we have social workers that are trained in all of the different types of plans that are available. They can get some individual information from the patient about what types of treatments they're receiving or maybe medications that we need to ensure are going to be included on the formulary. And then we can help guide them to all the information about the different choices. The caveat to that is that we do not make choices for patients. We make sure that we just give them some information in an agnostic form and we allow them to make that choice. So we all heard about the Inflation Reduction Act. We've heard a lot of talk about a cap in out-of-pocket expenses, but not everybody really understands exactly what this means. And it's confusing even in the healthcare arena. So what we know for sure is that the out-of-pocket cost for Part D recipients is $2,000. Now that is if those medications fall under the prescription benefit. If they fall under the medical billing benefit, then that is not part of this. The beneficiaries have to opt in if they want to utilize the Medicare Prescription Payment Plan. We know that $2,000 spread even over a year can be a real cost burden to many of the people that are on a fixed income. And the term smoothing just means that they're spreading that out-of-pocket cost. It's almost as if they're loaning the money up front, paying for it in advance, and then you're paying the plan back for that $2,000, but over the course of the year. And so a lot of people wanted to know when this change was coming into effect, how does that impact my ability to apply for help with different charitable assistance organizations like mine? And the bottom line is that you can elect to use the M3P or the smoothing plan, and you can still receive assistance from nonprofit charitable assistance programs like ours. So the way that our funding model helps is it does help with things that are outside of those medication copays. So if someone has already chosen their smoothing plan and they're making those monthly payments and they apply for assistance at my organization or one of the others, if you do that, say mid-year, and you're already making this monthly payment, that monthly payment is towards medications that were filled earlier in the year, and they would fall outside of the time that dates of service would be covered. So in those cases, we wouldn't be able to help with that monthly plan, that payment. However, if someone were to come to us at the beginning of the year, and this did happen a few times, if they had already elected that payment plan, and say an example we had happen was someone had 2 medications lumped into that $2,000 total. $1,800 of that was a medicine that we covered. So they just provided us with the invoice. We paid the full portion that we would cover under that. And then the remaining balance was the patient's and was made in much smaller payments throughout the year. All right, I think that covers just about everything. I know that there's a lot of questions still, even that I might not have thought of. So I think this would be a good time to open the floor up for questions. And I can't see, so you'll have to let me know if I should switch my view. I know I went really fast too. I just realized.
You can stop sharing your screen if you want, and we'll give everyone a few minutes to submit their questions. Thank you for this presentation.
I can go over a couple of our common questions that we get asked too, like on the frequently asked, because sometimes, again, those we think they make sense when we see them, but they may not necessarily to someone who's just not used to this world of financial assistance.
Absolutely. I feel like everything is very overwhelming right now for everyone. They don't even know what to ask first.
Let's see here. So let me go to our frequently asked questions. One thing I always like to say, and I'm not sure if I've talked to you about this before either. One thing I hear often when I'm out and about in the different conferences where I'm running into provider groups, especially, they say things like, "Well, I never send people to you because your program's always closed." Well, when they say that, I say, well, tell me what you mean when you say closed. Well, it says at capacity. They don't necessarily recognize that we have a wait list that we maintain first come, first serve. So if, say, we'll use GIST, if GIST is full at capacity, and let's just say, for example, this would be a perfect world and I wish it were true. Say there's 10 people in the line and that's all there is. And we open up 5 slots every 2 weeks. Only those first 5 people come through the door, but then these other 5 move forward, and it still looks like we're at capacity because we are. But if you never join the wait list, you never get a chance to move up to that front door. So I always suggest, if anyone thinks, especially someone with a new diagnosis, might not have any idea what they will need, go ahead and sign them up wherever. Because if that funding becomes available and the patient's already had their need met, they're getting medicine directly from the manufacturer, which is great, then they can always say no thanks. It isn't just there's no commitment involved when you do the application process. So I do like to point that out, and I'm not sure if you all ever hear that in your front door, so to speak.
That's good to know. I think we should start promoting more to just ask for the help. And if it turns out you don't need it, great, but at least you're on that wait list in case things do happen.
So some people ask about what happens once the new year comes. Am I still eligible? Do I need to reapply? And at this time, what we've done is shortened our response time down. It used to be 30 days. And what we found was sometimes people didn't need help anymore and they weren't paying attention to that call, which I don't. If people reach out to me and I don't need anything and it's not someone I know, I'm not always taking time. And so we now ask 10 days for people to just say, yes, I want to apply. I'm going to get you the paperwork. We still give that 30 days window for people to get paperwork. Sometimes it can be hard to get the medical care provider statement, but we have recently started where we can fax directly to a provider's office. So when you apply, you can go ahead and make sure you put the right doctor in there, maybe that would certify that illness, and then you can just ask us. We will go ahead and fax them for you and get it back directly. So it takes you out of that one more layer. Let's see. Another question I see is about the status, and we get asked both from patients and from provider groups. So if you were helping a patient out and you applied on their behalf and you're maybe a specialty pharmacy or you're an oncology group that is getting someone started in treatment, you might say, well, I've applied for them, but now I've heard nothing. We have to give our direct decisions to the patient. So the best advice I give to groups, if you're applying on behalf of someone and they have any tech, like even an email, and they don't necessarily get online a ton, use that, because you can help instruct your patient to go ahead and get a portal, and we can get information almost immediately sometimes, but it takes a lot longer if we have to send things in the mail.
I do have a more general question. Do you
Yeah.
have any major advice you can give to someone dealing with their insurance company, their Medicare, who, let's say they're not approved? Any advice for advocating for yourself with your insurance company and maybe some common mistakes patients make?
Yeah, I mean, that isn't my biggest area of specialty, but I've certainly heard from our care managers quite a bit. One thing we see a lot of is people who don't know that they can appeal. And so that's, I hate to tell you, we send a lot of people right directly to the advocacy groups because you have peer-to-peer support. That's been so helpful, I think, to be able to say, here's the first thing that happened to me, and it happens to almost everybody who has GIST, because, right? I think another common unknown fact is that you have a case manager you can ask for at your insurance plan. I never knew that you could do that until the last 2 years. You have to advocate for it, and it's not easy to do if that's not something that someone is accustomed to having to do. I find that with just also sometimes we're dealing with a population that might be a little more used to saying, well, my doctor's already told me what to do, and so I'm just going to wait. And so sometimes it helps to even say, well, let's see if we can't find a younger generation person who's used to the tech stuff. Maybe they can set up a portal. Even with the insurance plans, you can always get on there and correspond in some ways, a little less intimidating. Another thing I always point out, glad you brought up that about like just different things someone might miss. Aging into Medicare for someone who's been working is really, really big if you're in the world of needing to know how you're going to pay for really expensive healthcare. Because almost all, I think all, I can't say for sure, we have to keep our programs separate from private to public. And because we maintain a wait list and because they are truly different programs, someone who is in our private program and ages into Medicare in the middle of a year will be removed from that list and put on a waiting list. And we start sending correspondence a year and a half ahead of time because we know what a big deal it is, but that's such an overwhelming time anyway. People are retiring, they're trying to figure out if they can retire, how much money they should retire with. And that's another thing I just got taught by a businessman this week. He is retiring small business, barely making it because of his disease. However, he's able to see what the different organizations allow him to make so that he can ask for help. And he may not necessarily get that help, but he knows for sure if he makes over that, he can't even ask. So he has to carefully adjust what he's going to take in payments while he's, in this new state of retirement in order to continue qualifying for charity. So there's just a lot of things that people don't think about until they have to, and maybe it's just helpful to have them on your
like a chess game sometimes, like I
worse,
make this
especially in
much, I
not knowing
can't
how to
get this.
play.
Yeah. It's navigating this is so hard for our patients. So I really appreciate this presentation, and you put a lot of points that I think we're going to talk about more as an organization to really promote the fact that you can ask for help. You might
Mhm.
not need it. Here's what you do. Here's the changes that are happening, to really point patients in the right path. So I really appreciate this. I don't believe
Yeah.
there are any questions, but if we do get any emails, can I reach out?
Oh, of course.
Awesome.
I do want to mention one other thing that Sarah and I talked about not too long ago when you say just being able to push out certain points to your organization. I mentioned this to her when we met, I think at ASCO. We were talking about people who are on, say, fourth line medications who are struggling to pay for those. We can pay for those out of the medical expenses portion. Unfortunately, it's a reimbursement, so people do have to be able to pay for it up front. But another big point that I don't think is thought about often in the Medicare community, especially, is they are so grateful for any kind of help, and their premiums come right out of their check. So they don't see it go away, and they don't think of it as an income that they're losing. So we can reimburse for Medicare premiums. And that is one of the biggest ways we help people who have, say, their medication is mostly covered, but they have funding available and they're still struggling to make ends meet. How can you do a shift? So we sometimes will suggest to think about that. If you were to be reimbursed for those premiums, maybe it's only $180 a month. That's your smoothing plan. So anyway, just one more little way to try to figure it all out. I appreciate you having me on today. And if you all have any questions, please do reach out.
Absolutely. Thank you so much, Jennifer. I hope
Yeah,
everyone has a great day today. Enjoy. Bye, everyone.
thanks. Bye.